Good evening, everyone. So, as we reach the last two abstracts for the day, we'll go back to basic epidemiology. So, first of all, the first paper I'm presenting answers a question which we often discuss with not only our patients, our colleagues, and among family friends, that with the increasing incidence of breast cancer, at least what we are seeing around us, is the use of hormonal contraception in any form increasing this risk? And this is what this meta-analysis by Torres et al. From Germany, they have tried to answer this question. So all epidemiological studies and clinical trials show conflicting results for a variety of reasons, because it's difficult to get rid of the confounding factors, the study design is varied, there's always possibility of an undetected malignancy, and the heterogeneity of the biological effect of the hormones. And we can't deny that there are proven benefits of hormonal contraception on reproductive health. This study aimed to summarize the existing evidence about the lifetime use, ever use of hormonal contraception and the risk of breast cancer in women of reproductive age by performing a meta-analysis, so that they would study modern contraceptives. They only used studies which were published between 2015 to February 2022. These studies should have enrolled adult participants in the age group of 18 to 55. Any formulation of hormonal contraception, estrogen, progesterone, any compound could be used, and any form of delivery could be used, be it oral, injectable, intrauterine, intravaginal, transdermal, or subdermal. Any duration of exposure was okay. And all studies had to be peer-reviewed observational studies which had a clear measure of the exposure and the outcome. Basic statistical methods were used. The authors have conducted a meta-analysis using 22 reports, out of which 19 were case-control studies, 2 were prospective cohort studies, and 1 was a cross-sectional cohort studies. A total of 22,75,300 women, from which around 1.9% women, approximately 44,000 women, had developed breast cancer. 17 studies were from non-European countries, but 98% of the population studied was from the European studies because of the largest Danish prospective cohort study. And the method of exposure ascertainment about the kind of contraceptive used was different and of low quality because it was verbal and on recall basis in 75% of studies, and there was substantial heterogeneity in the studies. The pooled odds ratio, as per the study, is 1.33. So the authors have reported a 33% higher risk of breast cancer in ever users of hormonal contraceptives. Again, this is a pooled analysis of irrespective of the type or the method of delivery of the hormonal contraception. So they have reported a pooled OR of 1.33, and on subset analysis, the case control studies had a slightly higher odds ratio of 1.44, and studies that strictly defined menopausal status and studied mainly premenopausal women had a pooled odds ratio of 1.48. So they reported an even higher risk. So this meta-analysis using modern contraceptives says that seems to be an increased risk in ever users of hormonal contraception. Overall, the data is varied. Some have reported no increase, but 0 to 40%. We must remember that breast cancer development is multifactorial, and it's not driven by just female hormones, and the reproductive health benefit of contraception should not be discounted. Hormonal contraception should not be discounted. But in clinic, I think we need to make sure that the gynecologists and the obstetricians are assessing other risk factors, making sure that those opportunities in clinic encounters are being used to promote awareness and limit prolonged consumption. This study did not look at duration, but other studies have reported more than 5 years usage leads to an increased risk, and that increased risk can stay up to 10 years of cessation of hormonal contraception use. And we do need further research about the exact dose type, timing, and duration. Moving on to the second study. This was published in JAMA Oncology, and the authors are all from the International Association of Research Against Cancer. And they have done a meta-analysis reporting the global stage distribution of breast cancer at diagnosis. So the Global Breast Cancer Initiative, launched by WHO in 2021, is aiming to reduce breast cancer mortality by increasing the proportion of early breast cancers. They aim that worldwide, stage 1 and 2 breast cancer should be 60% of all breast cancer cases. The authors here systematically reviewed published studies using population-based cancer registry data to examine the state's specific distribution of breast cancer across countries worldwide. They have used studies which were published in the last 2 decades, from between January 1, 2000 to June 7, 2022, containing data from 2000 to 2019. And where there were 2 or more sets from the same population, the same country, the most high quality data covering the largest amount of the population, most recent calendar period and widest age group has been used. So they came down to 133 reports, out of which 63 reports were used in the main analysis, 36 showed time trends, 22 showed age group, and 12 also reported the socioeconomic analysis. So overall, 2.4 million women's data with breast cancer from 81 countries has been reported. And they have said that distant metastatic disease the proportion is much higher in sub-Saharan Africa, Central and South America, and Central and West Asia. The highest is ranging from 5 to 30% in African countries, and low proportions, as expected, are reported from North America, Europe, and Australia, Oceania. So 33 of these countries, out of these 36 countries, had less than 10% cases diagnosed in the metastatic stage. And they have said that there's a decrease over the past 2 decades, from early 2000s to late, between 2015 to 20. There has been a steady decrease in the proportion of patients presenting with metastatic disease, from 3.8 to 35% earlier to 3.2 to 11% now. So the data, the highest proportion of metastatic patients was from, like I said, Africa, Kenya, Mali, Malaysia, and lowest numbers from Europe, Japan, and the US. Only 41 out of these 63 studies reported group TNM stage, so stage 1, 2, 3, 4, and 40% of the countries out of this group also did not meet the WHO target. Also, the unknown stages were quite high. Almost 50% of countries from Africa and Asia did not report, classified a lot of patients as with unknown stages. On subset analysis, they've said that apart from Western countries in these continents, older age and lower socioeconomic status also had the highest proportion of cases diagnosed with distant metastatic stage. So in fact, very interestingly, even in France, the older patients, more than 70 years old, had a significantly higher proportion of metastatic disease compared to the younger patients. And in India, it was about 12 to 13% in the young and middle age group, and around 20% in the higher age group. So we are all aware about global disparity in healthcare, and that is seen in stage distribution of breast cancer. Although there is an improving trend in the last few decades, the gap needs to be addressed through increased awareness, improving access, and focusing on the lower socioeconomic strata and the older, and probably in our country, even in the younger age group, which tend to get misdiagnosed. And we also need to improve our population-based cancer registries. India did not report their stage 1, 2, 3, 4 distribution. This reporting is not being practiced. We are classifying a lot of patients as unknown stages, and I think that's something which we should correct at our own individual hospital contributions to the population-based registries as well. So thank you.